Welcome to the Public Health in Radiology series, where we start building conversations that are important from both a public health as well as a radiology perspective. Issues where a radiologist can play a very major role in addressing public health concerns pertaining to India. We start with a very important topic, a topic that has not often been, or that's not often discussed in academic circles pertaining to radiology, the issue of stillbirths in India. And this is part of the Samrakshan conversations. Samrakshan is a national program of the Indian Radiological and Imaging Association to reduce avoidable deaths of babies during pregnancy in India, and is led by Dr. Rijo Mathew Choorakuttil and a dedicated team of fetal radiologists in India. Samrakshan is operating, functional in several states and districts of India with a pan-India presence. So let's get to the topic of stillborn babies. How is a stillborn baby defined? The World Health Organization defines a stillborn as a baby born with no signs of life at or after 28 weeks of gestation. One important consideration here is that there are multiple definitions for a stillborn baby. For the sake of this presentation and for the sake of uniformity across global perspectives, we're choosing to stick with the World Health Organization definition for the moment. And that is that a baby is stillborn if it's born with no signs of life at or after 28 weeks of gestation. Stillbirths affect around approximately 7,000 families every day globally. And it's not just the loss of a baby. There is an emotional connect. There's an emotional loss. There's a social loss. In many settings, where reproductive rights and products of reproduction, if I may call it so, are important cultural issues. There are economic consequences that relate to perinatal well-being of the mother and the family in the short term and the long term, as well as other economic consequences directly related to the loss of the baby. So it's not just the loss of a baby. There's a whole set of contexts around that. Globally, about 98% of all stillbirths occur in the low to middle income countries. And India has the highest number of stillbirths in the world. That's a fact that we need to be aware of. That's a fact that we need to now start looking in the eye and that we need to start addressing. India has the highest number of stillbirths in the world, and close to an estimated 600,000 stillbirths every year. And the WHO, or the World Health Organization, estimates a rate of 22 per 1,000 births, rate of 22 stillbirths per 1,000 births. Now, when we talk of the rates, again, we need to be aware that definitions differ. The way of estimation, the methods of estimation differ. And so different studies, different surveys from within the same country can give rise to different estimates. And until we have uniformity, standardization across the categorization, definition, categorization, ascertainment of stillbirths, we're going to be faced with differing estimates from within each country. And that's a global problem. It's not just India specific. However, what we need to realize is that whichever estimate we are looking at is probably an underestimate because a lot of stillbirths remain unreported or undocumented. Why should we focus on stillbirths? The focus on stillbirths can save thousands of lives in India every year. Thousands. So what can a perinatal radiologist do? How can a perinatal radiologist or a fetal radiologist contribute to the reduction of stillbirths in India? Remember, radiologists are not often or almost never part of the discussions around maternal mortality, neonatal mortality, stillbirths, perinatal mortality in India. Those conversations are driven by the developmental sector, by the obstetricians, by the neonatologists, perinatologists. Perinatal radiologists and fetal radiologists are almost never part of those conversations. And it's time that perinatal radiologists step up, bring to the table their expertise and experience, and show ways that they can contribute to reducing perinatal mortality and stillbirths in India. A good way to start would be to try to save one life at a time. If you look at the overall numbers, that may look daunting. But if you try to save one life at a time, we can make a substantial reduction, substantial progress in the number of stillbirths in India. Let's look at who is at risk. From India, we are aware that rural settings had 27% higher odds of stillbirths. Women in rural settings have 27% higher odds of stillbirth. The scheduled caste social groups had 11% higher odds of stillbirths. Scheduled tribes had a 26% higher odds compared to the scheduled castes. So you can see that the scheduled castes and the scheduled tribes have a significantly higher odds of stillbirths. Women with no school education had 43% higher odds of stillbirths. Women who are not in paid employment were 15% more likely to have stillbirths. And extremes of maternal age, the very young and the elderly or the older pregnant women were more likely to have stillbirths. Now, these are socio-demographic risk factors for stillbirths. These are factors that we cannot control directly. But we could, as radiologists and public health specialists, increase awareness in these groups about the risk for stillborn babies. Awareness among patients, among pregnant women, their families, awareness among healthcare providers as well. And also provide health education so that we can try to optimize and improve the uptake of healthcare services in these at-risk groups. A lot of the stillbirths occur at terms, closer to term, and it's important that both patients and healthcare providers are aware of the risk of stillborn babies, especially in these groups, so that they can take adequate steps to try and minimize the chances for stillborn babies. Coexisting medical conditions are a risk factor for stillborn babies. Anemia, pregnancy-induced hypertension, fetal growth restriction, fetal abnormalities, antenatal hemorrhage or bleeding, intrapartum hemorrhages and bleeding, and medical comorbidities. And some of the known risk factors for stillborn babies, stillbirths. Now, anemia, pregnancy-induced hypertension, fetal growth restriction are highly prevalent in India. Antepartum, antenatal, intrapartum hemorrhages are also highly prevalent in India. So it's not surprising that we have a high stillbirth rate in India. However, these are also conditions that can be managed medically. These are conditions, some of these conditions definitely have some preventative measures that can be used. It can be introduced early during the course of the pregnancy. Almost all of this can be managed medically. So there are ways that we can reduce the number of stillbirths in India if we get a grip on the management of the coexisting medical conditions. These are risks that radiologists can help reduce. May not be possible to reduce the risk for developing these conditions, but at least reduce the risk of effects from these conditions. As a fetal radiologist, as a perinatal radiologist, we need to now learn to expand the scope of how we look at fetal assessments. We need to focus on growth, environment, and the structure of the fetus. It's no longer just an isolated look at the fetal structure. To find out structural abnormalities, we need to be conscious and look consciously for fetal growth, starting from early pregnancy and the fetal environment, the environment in which the fetal nurtures itself. These are important considerations beyond the fetal structure. We need to move to a paradigms of customizing the risk for each individual woman. Risk assessment, targeted scans for each individual woman, pregnant woman, fetal Doppler studies that can give very valuable insights into fetal blood flow, insights into the development of certain comorbid conditions, especially pregnancy-induced hypertension, preeclampsia, fetal growth restriction, insights into the course of these conditions, valuable insights into planning childbirth. Radiologists also have to consider maternal assessments, maternal cardiac assessments, hemodynamic assessments, even as they assess the fetal well-being. An isolated focus on structural abnormalities alone is an outdated concept. It's been a concept that has been running in radiology in India, fetal radiology in India for a long time. That's an outdated concept. Fetal structural abnormalities have a significantly lower incidence compared to preeclampsia, pregnancy-induced hypertension, compared to fetal growth restriction in India and their consequences. So, an approach that focuses almost entirely on a TIFA scan, the second trimester, is an outdated concept. What do we know? We know that increased coverage and quality of prenatal care, preconception care, antenatal care, intrapartum care, and postnatal interventions by 2025. We're already close to 2021. By 2025, could avert 71% of neonatal deaths. It's about 1.9 million deaths, neonatal deaths. 33% of stillbirths, nearly a million stillbirths. 54% of maternal deaths globally. Considering that India has a very high incidence of neonatal deaths, stillbirths, and maternal deaths, improving the quality of care around pregnancy can lead to a substantial reduction of perinatal mortality and morbidity, both in India and in the global rates. We could argue that we need to invest and improve healthcare infrastructure a lot, and that may take time. Not a short-term goal, it's a long-term goal. But we have been arguing that, and we have been telling that for the past 70 odd years. So it's time that we step up and make more efforts. Even more important is the fact that we need to optimize how we use the existing healthcare infrastructure. How does radiology integrate with the existing public healthcare infrastructure in India, as well as with the private healthcare infrastructure in India? Is it an urban oriented? Is it a metropolitan oriented service? How well does it penetrate tier 2 cities? How well does it penetrate into providing services for rural populations? As we saw, the risk factors for stillbirths are higher in the rural, illiterate, unemployed populations. So how well does radiology reach out to them, especially fetal radiology, perinatal radiology? How well does it reach out to them? How well does it manage to provide services to these vulnerable groups? How do we optimize that, given that we have around more than 15,000 radiologists in India, and let's say few of them, maybe 1,000 or 2,000, may be practicing fetal radiology? How do we expand the reach of these services? Available interventions by themselves can reduce the three most common causes of neonatal mortality: preterm, intrapartum, and infection-related deaths, by 58%, 79%, and 84% respectively. Just optimizing and expanding the reach of available interventions can lead to a very, very, very substantial reduction in perinatal mortality, early neonatal deaths, stillbirths. Fetal radiology has a very important role to play in that. And it's time that fetal radiologists and radiologists in India start to look very carefully, map out where the resources are distributed, and look very carefully at how they can expand their services to cover rural populations and vulnerable populations more effectively. If you're a pregnant woman, what you need to consider very carefully is that you have to ask your doctor at each visit, how is my fetus growing? How is the fetal environment? How is the fetal structure? Very important. Ask your doctor, what is my customized risk for some of the common conditions that affect fetal well-being and childbirth in India? Pregnancy-induced hypertension, preeclampsia. Am I at risk, a higher risk for preeclampsia? Am I at higher risk for having a fetal growth restriction, a growth-restricted fetus? Am I at higher risk for a preterm birth? What is my risk? Am I at higher risk? And if I am at higher risk, what should I do? If you're a healthcare provider, if you're a radiologist, fetal radiologist, perinatal radiologist, you have to make the same assessments. And it's prudent to explain to the pregnant woman and her family limitations of the customized risk and scores, and tell them that this is what you're finding and you're at risk, and what does that mean? And if you're not at risk, what does that mean? And provide a customized plan for follow-up care, follow-up assessments, follow-up scans. It's time that the communication, counseling around fetal scans expands to cover these aspects and to start making the pregnant woman more of a participatory element of the care process. Very important. We have to start discussing about stillbirths in India. It's a topic that we have left, that radiologists have left public health specialists to look at, to a very minimal extent to the obstetricians to look at. It's a topic that fetal radiologists, perinatal radiologists in India have to seriously start looking at, seriously start discussing about, because there are several ways you can contribute to a very, very substantial reduction of stillbirths in India. That discussion has to start now. So Samrakshan, as I mentioned at the beginning, is a program of the IRIA that aims to reduce avoidable deaths during pregnancy in India. Perinatal deaths, perinatal mortality is a focus area. Samrakshan is building a focus on growth, environment, and structure. Fetal growth, fetal environment, and structure. A complete paradigm. Samrakshan is looking at building skills to provide a customized risk assessment for every pregnant woman that you see. Samrakshan recommends fetal Dopplers for every pregnant woman in each trimester. Samrakshan focuses a lot on optimizing effectiveness of existing infrastructure, existing personnel, training, documentation, research, all of which are pragmatic and aimed at improving the situation at the ground level, with a focus on Tier 2 cities and rural areas. These are not feel-good courses, feel-good training programs meant to improve the reputation, massage the egos. These are courses, training programs, inputs with a significant amount of hand-holding, meant to translate into action, especially at Tier 2 cities and in rural areas. Learning in Samrakshan is peer-driven, mentor-driven, primarily peer-driven, with sharing of experiences from diverse settings. You can be a part of the movement that Samrakshan is building, part of the movement that aims to address stillbirths in India. If you're interested, please drop an email to samrakshanira@gmail.com and we'll be happy to get back to you and see how we can work together. The focus for Samrakshan: saving lives, one baby at a time. One baby at a time to address and reduce the huge number of perinatal deaths that we have in India. 70 years after independence, I think it's high time that we change our profile, the profile of our country as a capital of perinatal morbidity and mortality globally. I think we owe that to the countless women of this country. I think we owe it to the future generations of children that are born. I think it's time that we step up. I think it's time that fetal radiology, perinatal radiology starts to lead. So let us start a movement that addresses stillbirths in India. Radiology become an integral part of the public health efforts aimed at addressing stillbirths in India. Aligned with all perinatal care stakeholders, obstetricians, neonatologists, intensivists, critical care specialists, geneticists, sociologists, the developmental sector. A complete movement. Fetal radiology has a very, very important role to play in this. It's time we step up, and we hope that you will join us in this moment. You'll join Samrakshan in this moment. Become an integral part of the team, Samrakshan team, and lead so that India can claim its position, a proud position the global medical fraternity. Time we shed dubious distinctions of having the highest rates of several morbidities, mortality rates globally. It's time we do that. Time we step up. Thank you. See you again soon. Till then, stay safe. Have a good time.